Morning, Chairman. My talk today is about THA in the failed internal fixation. I'm talking about both in the proximal femoral side and also the acetabular fracture. We start with proximal femur first. Even in the case of the femoral neck, head, or in the throat, they can have a failure from non-union, also necrosis, and also the bursitis. The problem of a case of this group is because the patient have a retained implant. Sometimes they have a problem of proximal femur deformity and also the adductor deficiency. This group of patients have less problem of the loss of the bone stock comparing to the case of acetabular fracture that we may mention later. So the surgeon have to do the preoperative evaluation in the two aspects of the patient assessment and also the deformity and the bone stock. For the patient, you have to do the range of motion exercise, also the leg laying, including the hip strength muscle, gait, and spine problem. And the point is, you have to exclude all infection before surgery by using the ESR-CRP or lab analysis. And alternatively, if in the case of substitution, you do the frozen section or the culture for exclude the infection. For the bone stock or deformity, they do the standard radiography. And sometimes in the case of the stabilization, we do more investigations like a 2D view. CT scan may be necessary in some case because of this group of patients has a deformity, especially is a varus deformity and retroversion, but I not recommend to do that routinely. You have to have a backup plan for the case of infection. You have to discuss the patient before surgery. Sometimes, if the infection is not ruled out, you do the two-stage total replacement by the debridement and remove our implant first and use the spacer. And usually come back to the second stage after 6 to 8 weeks. This is an example for the case of neck fracture. Failed fixation with infection, we remove our implant first and do stage THA. For the technique, starting with a surgical approach, do the standard surgical approach as you prefer, but I do not recommend to do the MIS or direct entry in the case of this, because the approach can do more tensile exposure, or sometimes you need an ETO to go straight to the canal that sometimes have a proximal deformity. The point is the trick. You have to dislocate the hip before remove the implant, because sometimes with the forceful dislocation, you can make a crack or fracture of proximal femur. So dislocate first and then remove the implant. And every time try to protect the abductor mechanism. For the type of stem, you can use both the cement or cementless, depend on the age or status of the patient and also the prefer of the surgeon. Most of the case, I use the cementless prosthesis. Usually, I can use the primary stem type, like a metaphyseal engaging proximal fit stem in most of cases. And sometimes you need a longer cylindrical stem or the other type of stem at the backup plan, or it depends on the preoperative templating. We can adapt using a Proposky classification to have a useful for this type of patients. This is an example case that failed fixation of the neck by screw or the intertrochanter with the hip screw and also the proximal femur. We can use a standard primary stem with a similar proximal fit stem in the case like this. But sometimes with the deformity in this case, you see that all around the trochanter is unstable, so we need a longer stem. And as the case of already do the osteotomy like this, we need a longer stem to convert to the cylindrical stem. And in a group of this patient, we need to protect the other complications as I show on my slide. For the acetabular fracture, the patient can have a complication like a post-traumatic arthritis infection and also the hip dislocation after surgery. In this group of patients, we have to pay attention more for the bone loss and deformity, and also protect the sciatic nerve and prevent the HO in the case. Same as the previous group, you need to exclude the infection first before operation. And sometimes to have a more detail about deformity, sometimes this group of patients needs a Judeville CT scan. And for the planning of the bone loss management, this is In this case, the patients have heard about the proximal femur and also the sternum fracture. There is a plan to use the augment. You need show this case show the 3D view and also the CT scan preoperatively. For surgical techniques, the more the same. Avoid necessary dissection by remove the hardware that already protrude into the field. During you remove the sternum, if you see some screw, you can remove it, but after you left inside. Usually I use the seamless cuff, but we also prepare some bone graft or metal augment or case in some case necessary. For the prevent the complication of this group have more risky for the heterophysic ossification, infection also, and dislocation. This case, they have an infection, we have to remove and infection and also the dislocation before the total hip. We have to remove our implant to use the two-stage total hip, and we intraoperatively we have to lengthen the femur to protect the dislocation. You see the femoral head have a skirt, and luckily, finally, the patient have stable hip. So in summary, in group of this case, you have to rule out the infection first, use the proper policy choice. You have to plan for the bone loss management, and also prevent the other complications coming. Thank you.
Thank you very much. Questions from the auditorium? From my side, again, rule out the infection you mentioned. Does it mean that you recommend to aspirate these cases in every case preoperatively? And if yes, what do you aspirate? The joint or the plate?
I don't recommend to do the aspiration in our case. We just do the blood examination with the ESI CFP first. If it's suspicious, we do sometimes we do aspiration. But as you know that in my hospital, many times that you see the culture is always negative. So finally, we have to make a decision intraoperatively. You see that many times I do the two-stage, because even intraoperatively no show, we do the two-stage, safety first.
Okay, thank you.
Okay, thank you.